right, guys, ready? Okay, you tell me when. Hello, everyone, and welcome to our cardiovascular imaging conference. Today, we have a very nice topic that I think in the contrast world is unique really for imaging. And the reason for it is, we talked about it before, is that contrast echocardiography or using ultrasound enhancing agents, even with agitated saline, not only gives you some diagnostic information, but also interacts with your machine settings. So you need to understand the machine settings. How does it interact with ultrasound so that you get the diagnostic modality that you want and diagnostic impact that you want, otherwise you will be disappointed. To start with, we've used for many, many years agitated saline to look at shunting within the cardiac chambers or within the pulmonary circulation. And part of the reason that it is important and it has significant impact, it was because these bubbles are relatively larger. They can be initiated by just agitation of saline or any other solution. And the size of these bubbles is about 10 microns and could be more, could be a little less, but certainly larger than red cells. And part of the reason that they don't cross the pulmonary circulation is that, number one, they're fragile, they don't have a robust shell, and two, they're large enough to be entrapped in the pulmonary circulation. So it's because of these two things and exposure to oxygenation in the lung situation that normally you should not see contrast coming to the left side of agitated saline or any other solution. In the past, we mixed solution saline with blood and gives you more echogenicity, if you will. So these tiny microbubbles resonate and reflect ultrasound. And that's why you see this white, contrast coming in to the right side of the heart. Two other things, since I can take the advantage of talking about it, is differentiation of patent foramen ovale from a pulmonary AV fistula, if you will. Yes, patent foramen ovale can occur early, before 3 or 4 or 5 beats, but it doesn't have to be necessarily occurring early because it only depends on the gradient between right atrium and right and left atrium. So it can happen late if that gradient changes, but typically it happens early. As opposed to an AV fistula, it occurs always late, is not affected by Valsalva maneuver. So if you see it, if it is there, and on the non-Valsalva one, you don't see any contrast, you don't have an AV fistula. And the last thing, which is also important, the contrast builds on the left side as opposed to being episodic, right? So watch this. You could see there with inspiration or other things that happen. Look at the bulging of the interatrial septum, and you see a puff of contrast coming into the left atrium, and it's episodic. Large and then small, and if it happens again, you have it large again and then small again. All right, so that's important for our overall evaluation if there is any shunting. Also, you can use it in case this is an important question for you to answer, which is what's the pulmonary artery pressure, and you can enhance a jet, because obviously these microbubbles interact or act almost like red cells, right? So you can enhance almost a tiny amount of tricuspid regurgitation for you to be able to estimate from the modified Bernoulli equation an estimate of RV systolic pressure and most often PA pressure. Now, this bubble technology over many, many years, I would say close to 20 plus years, almost 30 years, evolved over time for us to be able to inject a contrast or ultrasound enhancing agents that would cross the pulmonary circulation that would avoid the issues that we just talked about, size, etc. So these microbubbles are more robust. So you have to think about a shell that is more robust, that can withstand, if you will, the resonance and the energy of ultrasound that is sent to them. You think also of what is inside the microbubble, as opposed to agitated saline or any fluid. It is not necessarily air, and most often we use high molecular weight gas. And what's the influence of pressure, of the arterial pressure? Remember, these go from a venous pressure, which is rather low, to an arterial pressure, and how well does it withstand? I remember Albunex, the first contrast agent, which we're not using anymore, was very sensitive to pressure. So every time you have systole on the left side, contrast decreases significantly. So it was kind of bothersome, but it was a success because for the first time we were able to cross the pulmonary circulation. So the first three in yellow are the agents that are available in the United States. The ones in green are available also in Europe. I haven't really kept up with that and see how well they're used, but the first three are important agents that we use. Definity and Lumason have a lipid monolayer as opposed to denatured albumin. And there's maybe an issue of more anaphylactoid reaction, and I was told also by experts that it could be at times anaphylactic reaction that could have been potentiated by the PGE that we use also for vaccines, mRNA vaccines. So we have to be ready in a laboratory if somebody has significant hypotension, allergic-like reaction, anaphylactoid or anaphylactic reaction, to be able to address this urgency. This is still very infrequent, but I think it's important for us to share that when you talk about contrast agents. Remember, this is a drug. Now, the impact on image quality is amazing because all what you could see on the left side here is a little descent of the base of the lateral wall, and that's about it. Can't say much about what the heart looks like. And if you use one of these agents, here you go, you can almost have the lights on, and in nice contrast that delineates the ventricle, its contraction, its endocardial motion can delineate also the muscle itself. So let's talk a little bit about mechanics and what we should avoid, what should you understand, because if you're a user of it and even an interpreter without you actually injecting, you need to understand what you're dealing with. What I'm going to show you here is a bolus injection of a contrast agent. So obviously it's going to go from the right side to the left side. The first thing that you're going to see, and this is here, this is the right side of the heart. What you're going to see predominantly early on is a film of very high white density. Okay? And the reason for it is ultrasound beam is coming this way, and this is very dense. So it's going to reflect the ultrasound only of this surface. All this area here will be black, and the reason for it, it's hiding behind, it's attenuated. It's almost like you have a piece of calcium or metal because it is so dense. Now it goes to the left side, and you're going to see it gradually coming in very nicely. But ultimately, because you have not diluted it or you've injected too fast, that the concentration of contrast is very high. And if the concentration of contrast is very high, it's going to act similar to what you've seen here. Basically, you'll see a reflection up to almost the tip of the heart, and everything else is black attenuated, because you're reflecting all the ultrasound backward to the transducer, and you're not allowing anything to penetrate even further. Now, what you do in those situations, you can wait a little longer, right, for it to pass and dilute, and therefore you can see through. Let's take a look at this injection. Remember what I told you, okay? Now contrast is coming in into the left ventricle, nice and dense, and you could see a flame of black. It's not like you don't have contrast, actually you have too much of contrast, right? So that's all what I can see, and everything else is attenuated behind it. So lesson number one is don't inject too fast. I think most contrast agents are diluted now in about 10 cc's of saline, and you'll get a hang of it, of how much do you inject, so you don't have this attenuation issue. Now, I mentioned at the beginning that, with ultrasound, you interact with these bubbles. And remember from our first lecture on mechanics and ultrasound physics, the ultrasound is a positive pressure, negative pressure waveform. So just think about these tiny microbubbles, which are usually in the micron range. So you're talking about 2 to 3, 4 microns or so. In the positive phase, they're compressed. They're not destroyed. But in the negative phase of pressure, they can be pulled apart and destroyed. So, and you're talking about here, tiny milliseconds, or even microseconds. So you're not gonna wait for this to compress and decompress. But this is at least to illustrate what the effect of it is. So you have to be very careful about what the energy that you're sending through this ultrasound beam. And this is called the mechanical index, MI. It is peak negative pressure divided by square root of the fundamental frequency that you're sending this, frequencies through the transducer. So if you plot the mechanical index, meaning this is low power and this is high power, and for your information, for us to take a look at the heart, usually without contrast, our mechanical index is about 1, 1.1, 1.3, something like this, okay? So if you send this high energy to these ultrasound tiny particles, you're gonna destroy most of them. You're not gonna be happy of what you see. So we have to decrease the mechanical index to a point where we destroy much less, so you're able to opacify the ventricle and be able basically to take a look at it. These microbubbles will resonate just like we talked about it, right? For every pulse of ultrasound. Now, here you go. This is now the effect of a mechanical index on the ultrasound that you see, okay? So you're going to have a mechanical index of 1.5, which is quite high, and I'm going to decrease that over time, and you'll see the difference. Basically, as this goes down, 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 there is much more full opacification of the ventricle, and this is for the same injection. Let's take a look. See here how you have population of blackness in addition to contrast. It's not like the contrast is not there. It's there, but it's close to the transducer and being destroyed. And as you decrease this, you go, now it's at 1.5. I'm going to start decreasing it. There you go, coming down, 0.2, 0.3. Nice full opacification. So if you're seeing something like this after an injection, you have to take a look at your setting, because the MI will be quite high. And the way you suspect it is I have a decent injection, a decent opacification of contrast here, yet in the apex, it looks like almost like a hurricane. It is a mixture of contrast and no contrast, and you'll see it there. Interestingly enough, okay, I'm showing you a case here of a normal heart. At times, if I have an apical infarct by itself, and I decrease the mechanical index way down to 0.2, I may still see this hurricane phenomenon. Why? Because these red cells and this contrast is stagnating in the apical cavity and being bombarded no matter what I do. So you try to inject more, hoping that you get a little more, but in a true apical aneurysm, at times you may see this swirling mechanism no matter what you do, and you try to decrease the MI as much as possible. One thing you could do if you want, you could image intermittently, so you're not bombarding them all the time, but this is, you could be innovative, if you will, and you could do that. You could do that, okay? So, we talked about in the early basic science of ultrasound that we send ultrasound at a fundamental frequency, And we also talked about that these microbubbles are very resonant. You'll hit it and it will emit frequencies that are not only in the fundamental range, but there are multiple of those frequencies. So let's say I image at 1.5, that's what I'm sending. And if I'm listening at a harmonic, which is 2 times 1.5, second harmonic, I'm going to emphasize the structures that are much more resonant than others. And we know contrast is much more resonant than myocardium, so you're going to emphasize the contrast much more than the myocardium per se. Okay? And so they produce harmonics. And here it goes. This is the same injection, same patient, just microseconds apart when you turn harmonic on or off. Okay? Harmonic is off. Contrast is in. Not pretty. Not pretty. Why? Because contrast is almost the same intensity as myocardium, and it's all blurred. Okay? So here is 3.5 megahertz fundamental. And you will see an H where it's harmonic, and you'll see the difference in this. It'll go from horrible to beautiful. There you go. Harmonic. And you want to decrease the MI, so decrease MI so I can have a decent. And you had a blip of fundamental. Watch, decrease MI, up, fundamental. That blackness, that basically uniformity. So for us to image well, we have to understand mechanical index. And the good thing is nowadays you have presets. So if I'm using contrast, I'll go to the contrast preset, which presets it down to a lower mechanical index. You still have to know how to inject it, right? And use harmonic. And most of the time nowadays you use harmonic even for regular imaging, so it's lesser of an issue, right? So I think these are the major principles. So let's go through some applications and some cases so we understand some of these applications. It is FDA approved. These 3 drugs that we talked about are FDA approved. And the one on the left is the major indication that is approved, which is improvement in endocardial border definition. By definition, if you have 2 or more segments of these 17 segments that you don't see and you really need to see, you use contrast to enhance it. Because most of the time, if you don't have 2, I'm not seeing, most of the time it's more than 2, right? Now we use it also for enhancing of Doppler signals. This is not an approved indication, if you will. Myocardial perfusion, not an approved indication. A lot of research on it. I think it's kind of less of an impact at this stage of the game. And for some therapeutic areas, you may have, we're not going to go through it, but it is to enhance thrombolysis actually in acute myocardial infarction, because you have the resonance that these could be tagged to the thrombus, and then you'll have more resonance, so you'll improve lysis in addition to the regular thrombolytic therapy that we use. So these are the guidelines for you. One in 2008, one 10 years later, 2018, and they are still very applicable. So for you to peruse, and hopefully by now, those of you who are in the field should know these and their applications. And this is, in general, the clinical applications: improved border definition, be it regional or global, delineation of LV hypertrophy, because part of it is if I delineate the border, I know what the thickness is, rescue of uninterpretable studies, particularly in the ICU, we'll go through some data, improved stress echocardiography, Doppler signal enhancement, particularly for aortic stenosis, and definition of structural abnormalities. Is there a thrombus or is there a pseudoaneurysm that you want to take a look and see if there is a connection between the ventricle and that chamber that you're seeing. And they are part of the appropriate use criteria by the ACC. These have not changed. The major indication is, again, as we said, that we're not seeing all the segments. And if I'm seeing everything, it is inappropriate to use. So case here that I always show, this is a preview of, many different ways. I can't see this heart. You can decide for yourself if it is a depressed ventricle, yes or no. But really, in 2023, wherever you are in the United States, and hopefully in countries that have used echo, that used ultrasound contrast agent, yes, they may be expensive. Here in the United States, $100 plus or minus, something like that. It may be expensive for people in other parts of the world. I'm not sure what the actual cost is. But in truth, if I do an echocardiogram and charge a patient to try to understand what ventricular function is, I'm not sure I should charge that patient, or at least I would get the information I need if I use contrast. So, in truth, the use of contrast in an echo lab is quality driven, as opposed to reimbursement money driven. So if you're in it to provide the best diagnostic accuracy for patients coming to your laboratory, you have to be the champion. And you is the physician, the director, the sonographer, whoever's involved, right? Because if you don't do that, it's very easy in the United States to say, technically difficult study, cannot evaluate ventricular function. It is less time in the lab, there's no IV, everything else, and your reimbursement is the same. What have you done for the patient? So I want you to think about that, because this is very important. And it was some time till laboratories used contrast agents. Use it appropriately, not indiscriminately, where it is needed, because utilization, I know we fought for this years. Utilization was less than 1% in this country. And we know it is much more than that. Should be much more, depending on the situation. I'll share some of these data with you. Now I think it's more available, not more available, it's always been available, more used in laboratories, I would say, appropriately. And you will see that obviously the inpatients, the instrumented patients, are the ones that would benefit the most, because they are the most technically difficult. All right, this is a ventricle that is depressed. Even a first-year fellow would know that this heart is not moving. Now, I cannot tell you every wall motion in this heart. I can see the inferior wall. I can see maybe the lateral wall. I cannot see the apex well, etc., right? So you won't be too wrong by saying that this is a very depressed ventricle, most likely an ejection fraction less than 25% or something like that. You won't go completely wrong. But you'd be missing something, because I'm not seeing it, right? You could see the thrombus very nicely there, and obviously somebody who would be at risk of an embolic phenomenon. So it would change, because I could not see all the segments, particularly in a depressed ventricle. In truth, I think if I have what looks like a normal heart, I'm missing maybe one segment or two, depending how strategic that segment is. I may not be at a major issue, as opposed to a bad ventricle where I miss an apical thrombus. So I want you to keep that in mind when you're doing echocardiography. Take a look. This is a case, and I want you to tell me something about it. Ventricular function, is that good? Yes? Yeah. Looks probably good. I'm guessing. I don't see the endocardium. I see the descent of the base. For those of you who pioneer descent of the base, it's good. This is this case. Same patient, hypertrophic cardiomyopathy, with a good ventricle. So one message is, if I don't see, I can't really interpret in the best ways. I mean, that's for the imager, that's foundational, right? If I can't see, how can I interpret? This one I will show because it is very unusual. This is a patient I was directly involved in. I was in the lab. This was in the early days. And I love to, because the eye extrapolates. It's beautiful how does the eye trick on things. I interpret it as normal. So our friend Dr. Kleiman calls me up and said, how could this be normal? The EKG is so abnormal. There's an infarct somewhere. I said, Neil, I mean, I can't see it, but I'll bring the patient back and do a contrast echo. Okay, so we bring the patient back. And here it is. A very unusual location of a wall motion abnormality that you could see on short axis is in the anterolateral wall, and distally, heart is good. So what my eye did is linked from 2 o'clock to about 4 o'clock. Right? That's what happened. I couldn't see the lateral wall well, and here you go. You got what looks like, actually, be it a pseudoaneurysm or aneurysm, turns out to be an aneurysm. Somebody who had a lateral infarct. Very unusual place, but real. I haven't seen a similar case since then, but that's okay. This is a teaching conference. All right. As you could tell, I like to build on historical themes. This is another historical theme. Mike Quinones would remember this very well. So our live courses in Bethesda. And this patient actually came in Georgetown. And this patient came the night before with chest pain. Okay? Not your normal EKG. And this is the echocardiogram. So I want you to think of how you interpret this echocardiogram. This is what you see. So if you're in the echo lab and don't have contrast, I know you do now, but don't have contrast, how you interpret this? I can't see the endocardium well. I have a suspicion of an apical abnormality which could go along with the electrocardiogram, but that's all what I can tell. So if I'm stranded in an island without contrast, okay, I say suspicion of an apical abnormality. Can't tell, right? And the clinician would have said, thank you very much, because that's what I was suspecting from my EKG. All right, so this is that patient. What is that? That's an apical hypertrophic cardiomyopathy, indeed, with at times maybe a little sequestration of an apical cavity that you see it from time to time, a little tiny one, but certainly an apical HCM, which goes along also with that electrocardiogram. This is your major differential in those situations, okay? How about this case? Tell me what you think. Is this normal? No. What do you see that is to your eye? What flickers? Can you raise your voice so I can share it with the audience? Apex is not moving well. Okay? Can you tell yeah, maybe. I'll go along with that. It's not completely normal. It's not moving well. Anything else? Inferior wall. If you tell me the first one, I would say inferior wall. The other one I have to guess, right? But Dr. Toro is on it. All right. So we're going to use contrast, and you could say to yourself, why would I use contrast in this situation? Okay. That's the contrast. Your apex is indeed not normal, Dr. Toro. But guess what? There's a clot. Isn't that interesting? There's a clot, and actually, in retrospect, using the retrospectoscope, whatever that thing is, take a look. You could see it. You could see something there, but I have no idea whether this is real, yes or no. All right? Has changed quite a bit. All right. Let's take a look at this case. What do you think this case is about? How are you going to interpret this case? There's a lot of murmuring.
It's like hyperdynamic LV, probably mid to apical HCM.
Mid to apical HCM. That could be, yes. If you want to describe, obviously we're not seeing well, right? And remember one thing, hypertrophy is not usually seen well from the apical window. There's a lot of dropout. This is lateral resolution, a lot of dropout. Best seen parasternally, where you're more perpendicular to some of the segments. So I have a suspicion, I agree with you, of an HCM, maybe an apical hypertrophy from mid here. And notice one thing, which is also important in regional wall interpretation. Look at the epicardial border, as opposed to this epicardial border. There's no motion of the epicardial border as opposed to the normal areas. Because when the heart shrinks, longitudinally, radially, and circumferentially. So epicardial border goes down about 10% or so. And if I don't see a shrinkage of the epicardial border, diagnoses are two things. Your differential diagnosis is two things. One, a wall motion abnormality, an akinetic area. Two, crowding. Heart is crowded. You have no cavity inside. You cannot bring it in. All right? And that's what it is. Okay? So, and you could see even the arterioles, you could see them coming in. Nice, beautiful apical HCM. Okay, you heard what I told you about from a mechanical point of view. So I want you to interpret in that previous case that I show you these two frames. What are you seeing here? And what are you seeing here? Anybody? If you were attentive, the first 10 minutes.
First one on the left, I think we have a lot of contrast around the apex, so they're shadowing down. So we need to increase the mechanical index to just destroy the bubble.
Okay, let me translate that to the audience. Is too much contrast in the apex. There's shadowing behind. So what do you do in those situations? One, he suggested increase your mechanical index so you can go to the buttons and do whatever it is, destroy more, or
Inject slowly.
just wait. No, it's too late to inject slowly. Can't go back. So what happened on the right side, Dr. Toro, since you're taking the lead?
I think here, I think probably there is little. It's probably a little contrast there. We need more contrast in this.
Little contrast, we need more contrast.
Or I think there is slow flow, so some of the bubbles are getting destroyed.
That's the same patient.
I don't know when is this taken.
I think they went
It's
up
after.
on MMI. They went up on MMI.
They went up on the mechanical index. They followed your advice, Dr. Toro. They sure did, and noticed that contrast in the atrium is very decent, right? So as you get close, you see this hurricane heart, and this hurricane heart is a mixture of contrast and destroyed contrast. Usually if it is contrastopenia, low contrast, you see low contrast everywhere. You understand? See low contrast everywhere. So they went from an extreme to another extreme. Got it? All right. So all this is usual indications, usual things. All right. And here is, I can't tell the aortic stenosis jet well. Can I enhance it? All right. And yes, you can. You take a look at that. Unenhanced versus enhanced. You want to make sure that you don't overdo it, because if it can bloom, and it can give you about almost 0.5 meter per second higher. So wait for that intensity to come down, otherwise you're going to overestimate the gradient. If you're biased towards a patient to being intervened upon, yes, you can use this methodology, but please don't. Okay? All right. In truth, I have not changed the slide for the past 25 years, and it still holds true. And I didn't want to change it. I didn't change the colors either. The highest utilization, okay, of importance of endocardial definition is certainly in the ICU and instrumented patients, and we have data actually to support that. Outpatients is the least. That doesn't mean it's zero. Stress echo, it really depends on, but we know in stress echo, no matter what you do, exercise, dobutamine, etc., image quality goes down during stress compared to what the baseline is. So if the baseline is borderline to you, not pristine, you may want to err on the right side and do it. And yes, it's not a approved indication for it, but I think people use it, just like FYI, for your recollection or knowledge, that dobutamine is not approved for stress testing either, right? Like Persantine either, and for whatever. So we use a lot of off-label where we feel it is important and it makes a difference. Okay, and ICU, this is, my goodness, it's been a while. This is from, we did this study many years ago with Dr. Yong-Ki Young. And was a nice study, fundamental imaging, harmonic plus contrast compared to TE in the ICUs, to look at ventricular function. And actually, with contrast, you can get pretty much a good evaluation of ventricular function, even quantitation of ejection fraction in patients who are very difficult to image. This is from a study that we did on stress echocardiography. And you could see here, and another thought or advice, if you're going to make that decision to use contrast before you go through stress. So I use it, yes, no. So that all the images are with contrast, it makes the interpretation much easier, and err on the side of use as opposed to less use, unless the images are really pristine. And I would say, if the images are pristine, contrast may not be helpful, actually may be deleterious for you, because you have shadowing and you have other things that you have to deal with as opposed to beautiful images, and you may not be able to tell the right ventricle well. So, be careful about that. This one haven't changed either. I'm not sure about the zero anymore, but for many, many years, there are some labs not using contrast at all. I'm pretty sure if you go globally, that is definitely a true statement. There are some labs who use it 100% of the time, and I would not use it 100% of the time for the reason I told you, and we have data actually to show you. And I'm pretty sure if it helps you, it is cost effective in a way. This is from Dr. Juan Carlos Plana when he was a fellow with us, so you can date him a little bit. He heads the cardiology service line at neighboring Baylor St. Luke's, and we did a study that we don't want to do it again, where we did 2 dobutamines for a patient, one with contrast and one without. Yes, we could have done one interpreted before using contrast, but the problem with dobutamine is you have to continue infusing it, so you'll have an additional 3 minutes or so, and it's very hard to take that factor out from the equation. So we wanted to use actually 2 dobutamines and see whether you would improve overall interpretation. This is image enhancement, much better at rest in addition to peak exercise. That's what you would expect. Interesting enough, similar to a resting situation, if you have more than 2 segments not visualized, a major impact on accuracy compared to angiography. And I'll share with you a case here. That's not a straightforward case, but I'll share it with you. So this is a patient coming in. Can you interpret this for me? This is baseline, 5 mics, 10 mics, and 30 mics of dobutamine. How are you going to interpret this patient? A difficult one. Even to Dr. Safi, difficult one. Now, in truth, what can I say? is I'm wondering about a wall motion abnormality here and here. Here it's not impressive. Here I can't see anything really of the anterior wall. So I can find my way in between. Let's take a look at contrast. Major change in the overall interpretation. Here, I know at baseline, I already have a problem. I have an apical akinesis. So this patient had a previous infarct before, and notice what happened to his ventricle. He or she, I can't recall. Ventricle got bigger and more extensive ischemia. So a previous infarct with ischemia on this patient that I really could not tell well without contrast. So that's what I'm telling you about utilization. And I cautioned you on these are the ones that are really pristine echocardiograms. Some of them are beautiful images, no matter where, how. You should not use contrast. And the reason for it is contrast has its issues. And you have some linear shadowing. Whenever you see within the ventricle a linear endocardial, straight linear endocardial border, be careful about shadowing. And these are examples here. See this linear structure? The endocardium is behind it, is right here. So this moves during contraction and it fools your eye that indeed this is the endocardium and it's not. Same thing here. See this? Behind, this is where the endocardium is, and this is a linear shadow from the papillary muscle. Same thing here, and this is not from the papillary muscle, this is from some structure that is giving you a linear structure, and at times, you may not be able to see it. I mean, you tell me how you're going to interpret wall motion in this one here. Luckily, I can interpret it here, but here is a difficult one. Because that linear structure is moving along in the same thing, and it could be from the two-chamber view. Just look at this one here. So you usually, with contrast from the apical window, you're going to have some linear shadowing, particularly would be problematic for the base. Now, the good thing is, at least for the anterior wall, is less of an issue because if it's an LAD, you're going to see it more distally. But for an inferior wall, posterior lateral wall base, could be a problem if you're, if you have a lot of shadowing in that area. Okay? So it improves endocardial border definition. It translates into improvement in accuracy, appropriate contrast. At least in our opinion, in our lab, is between 50 and 80%. It's not 100%. And it's not zero either. And it's not 30% either. So also depends on the population that you see. If you're maybe at the VA hospital, you're gonna, with lung disease and other things, you may have to use more contrast. So it really depends on the situation. And for the sonographer, you have to optimize the image. You can't just, you have to optimize it at low MI, avoid foreshortening. You may find a different apical window that is better, less foreshortened. So you have to work at it, and that's why also you use contrast at baseline to adjust of where you see, what you need to do, etc. Go from there. Okay, what's the impact on diagnosis and management? And I think this is our also important contribution to the literature. A couple of days ago, we were in the lab when we talked about Dr. Kurt. We were wondering where he is. He came as a medical student from Turkey. And I was very impressed with him. I said, you stay a year and let's do a study on the impact of contrast in daily practice. And that's what we did. We had 632 patients consecutive who required ultrasound enhancing agents because of technically difficult studies. And we empowered the sonographer, just like we empower a sonographer every day, to make a decision whether they're going to use contrast, yes or no, in that particular patient. The non-contrast studies were interpreted separately from the enhanced studies, called the physician, and told them the results of the non-contrast study and said, what do you want to do now? If it is uninterpretable, if it is, wondering about a thrombus in the apex, or whatever it is, ventricular function, you name it. So they decided what to do next. either transesophageal, gated, nuclear, stress, CT, whatever it is that you want to do. And then we told them what the actual results were. And said, well, are you still going to go with that same thing, or do you want to do something different? So as opposed to you could do a randomized trial, if you will, to, et cetera, but I felt this one much more realistic, giving the physician online on the phone, there was no Epic at that time, on the phone what the results are and making that. All right, so by definition, obviously, the vast majority were red because they were very technically difficult and some of them were completely uninterpretable. The vast majority were much more interpretable. Is still some technically very difficult studies and a sliver of uninterpretable despite contrast, and that's what you use. And you could see, even after contrast, the ones in the surgical intensive care unit, almost 20% were still technically difficult. And this is reality. That's what you see. It's not 100% for sure that you're going to get much better images. And I think it's important to keep that in mind. The impact on additional planning procedures was quite significant. TEE avoided. The vast majority was almost 30% of them in the SICU to look at ventricular function. Nuclear, no procedural change in gray. Obviously, in the outpatient setting, the vast majority was not much different. An impact on medication changes. Hemodynamic drug added, anticoagulation started, or hemodynamic drug stopped, anticoagulation stopped because, the area of fuzziness or reverberation in the apex was no longer an issue for you to be able to do that. So this is the overall impact on management. The vast majority in the surgical intensive care unit. Actually, the no impact is only in 37%. And the least impact, as you would expect, is in the outpatient setting, still about 12% or so. So this is all guided by what? By whether I can see, endocardial motion, yes or no. And it made sense when I asked Dr. Kurt to say, why don't we look at the relationship of the number of segments that I can't see to the relationship of impact. And, it certainly made a lot of sense. If I didn't see a lot, obviously my impact was much more. All right, this is a quiz for you. Thrombus or reverberations? Need contrast. Oh, come on. You see this right quadrant that is empty? That's the one. All right, how many thrombus? Raise your hand. Okay, and how many none? Okay, we have about 40% thrombus, I would say. And Dr. Toro doesn't want to commit, although he was a proponent. And he was very vocal before. He's no longer vocal. All right, this is it. Okay, since this is an artifact, how do you, again, you're stranded on an island and you have no contrast, how do you take it, what procedure would you do to say, or to minimize this conundrum?
Take a different view.
Take a different view, right? Go up, down, maybe a short axis, and go down from the parasternal window and go down to the apex. Do a long, off-axis views that you need. That's one. Two. M mode won't help you because what you see, you're going to see on everything that you have. And most likely what you're going to see is you're going to see a color Doppler. Say that?
Is there TEE on this island?
Is there TEE on the island? Are you kidding me? Are you kidding me? This is either the Cayman Islands or, it is not available on the beach.
No point of asking for CMR.
All right. The other is change frequency. Change transducer, because many of these reverberations are because of the caseation of the casing of the transducer itself. So you change frequency, view, etc. Right? To take a look at that. All right. Next case. If we have a next case. Okay. How about this one?
Layered thrombus.
A clear thrombus.
Layered.
Oh, layered. Okay, got it. Layered thrombus. Okay, Dr. Safi, you're good. You're good. We have a layered thrombus. How about this one? What do you think? Tachycardic. Somebody is betting to go to Vegas, and I said, "You started with no thrombus. Thrombus. What should I do now?" I'm tricky. This one you're not going to be able to guess. That's pretty bad. All right, enhancement of Doppler signals we talked about. Just a few things here. Let's see, what time is it? Okay. Few things for you, because I think this is a science for many, many years, and I know you're not exposed to it, but I think you need to know that. If you think about velocities of blood in the chambers and in the arteries, what's the usual velocity like? Centimeters per second, right? From 20, 30, 40, 50, 60, 70, 100, right? Aortic stenosis, more and more, right? So think, what is the velocity of red cells in the myocardium, in the capillaries? You have an idea?
It's going to be very low.
Okay. Can you give me a feel?
It's almost going to probably reach zero, almost. Not zero, close, because when the capillaries, like the venules and the arterioles meet each other, the velocity is very, very low at that time. But I don't know the number.
1 to 2 millimeters per second. Pretty low. So, if you think about contrast and the hope initially that, oh, I'm going to inject contrast, I'm going to see, blood flow immediately without adjustment, without anything at all. What are you going to do? You're going to bombard. If you see in real time, just like I showed you, you're going to bombard, these microbubbles that are moving just very tinily and exposed to ultrasound. You're going to destroy them, right? So you have to do something different for you to be able to see when contrast goes into these capillaries and venules, for you to be able to preserve it, right? And this is an example. There you go. I'm seeing in real time on the left, myocardium is dark. And that's part of the reason that when I enhance the cavity, I don't enhance as much the contrast if I use regular settings. Just decrease my MI and use real time. You understand? I'm destroying with that mechanical index because the motion is so little in the myocardium. I'm destroying everything that pretty much in the myocardium. Unless I use, on the right side, intermittent imaging. I let the contrast come, stop imaging, recover, image one time, and then stop again. So intermittent imaging. Got it? That was discovered by Dr. Sanjeev Kaul, Kevin Way, Jonathan Lindner, and Jonathan Lindner is back at University of Virginia now, and Dr. Kaul is doing mostly basic work. But I think that was very ingenious. Why? Because they said, well, if I image intermittently and watch contrast come in again, I can use this as myocardial blood flow. So actually you can. It takes technical, in addition aptitude and other things for you to be able to see it, but you're not going to see this heart contracting like this. You're going to see it, flashing, and I'm looking mostly at contrast as opposed to wall motion. You understand? Using this technique, which can be quantitative, looking at the slope of contrast coming in, tells me how fast it's coming in, and where it plateaus, and the plateau is total myocardial blood flow. Part of the problem, in contrast,
Are we talking about perfusion study?
yes,
Perfusion study, is that what we're, okay.
part of the issue with contrast per se is these contrast microbubbles are coming into the arteria, into the capillaries, right? But also they get out into the veins and they straddle a little bit longer in the vein. They move very slowly, and people have looked at that. So that's why it is not as simple as I'm injecting, I'm taking a look, and I can quantitate ventricular function. So another way of doing it, this is here, real-time perfusion, but I have to destroy them a little bit. So you see this, low MI. So I have low MI, and then I hit this myocardium with a high mechanical index. I destroy them, but it's at one point of time, and watch it come back and fill, okay? And we did a lot of studies in that. Here you go, that's at baseline in somebody. Here you go, that's high MI. You could see it gradually filling. And with dipyridamole, where you can increase myocardial blood flow, a high MI comes. It will be coming. There you go. And then you watch it fill. And obviously it fills much more here compared to the apex, where you have also a wall motion abnormality. A little more tedious than your regular imaging. Has not really, I mean, there are a lot of studies, and we were, one of the sites that did, quite a few studies. You could see Dr. Shimoni there, number one, and many others. And Dr. Porter, certainly Tom Porter has done and still does quite a bit of contrast. The additive value to wall motion is still a bit questionable at this stage of the game. And we don't have an indication, a true indication currently, and no indication for it. So where we use it judiciously, we have not really used it. We have really not used it in the lab from a clinical point of view. It's great for research. And the beautiful part of the research, particularly in animal model, is you could have repetitive injections, right? Quantitating blood flow under different physiological situations. And you don't have that luxury at the myocardial level to do that. Yes, you could use microsphere labeled, nuclear microsphere labeled studies, but there's so much you can inject, and here you could see it in real time. You look at function, look at perfusion at the same time. So, in summary, part of the reason we do these is to educate people on how to use contrast echo, and believe me, we've been doing this since the inception of contrast. And it's good to see that although there is wide variation, it is better, and people are using it more appropriately. Please use it appropriately. And use with other technologies is still strained, I would say. Why? Because it's really not optimized for 3D, and I've told our colleagues in the industry that you have to optimize its utilization, because in 3D you're going to destroy much more contrast, so you're going to optimize the machine setting for this. Still, you cannot do strain with a contrast image. For perfusion, we talked about it, it's not approved. To me, is not as competitive with other modalities nowadays. You have PET, you have nuclear, you have other things, FFR. I'm not sure that it's helping me much more than wall motion per se, and you could tell the variability, particularly in the base of the heart. It's great for research though. Role in therapy, people are still using it for gene delivery. You can inject and then destroy at the, in the pancreas or another organ where you want to, do gene delivery. Exploration for use in vascular imaging, vasovasorum, still under development, but I really think, number one, from a clinical point of view, is here for you to stay and use in the best ways to try to help you understand situations. And hopefully our colleagues in industry will optimize that for 3D and strain so we can have the whole armamentarium together. Thank you very much for your attention. Questions?